Why'd you get into psychology? What drew you towards that?
I was actually originally not interested in psychology at all. I was interested in medicine, and I applied to medical school and didn't get in. This was in the early 90s when like the tech boom had just crashed and everybody was going into medicine. And also the ratio of male to females was like 80-20. So I was living in Queens. I had gone to St. John's. I was staying, kind of there to work and applying to med school. And I didn't get in, and I was working I had majored in psychology, and my, I guess, mentor, you could say, was a psychologist, and she said, you should really consider psychology. It's kind to women, it's different than medicine. I think you actually would be happier interacting with people. Medicine can be, very structured and very short, and healthcare's changing, and it was, and it's changed several times since then. So when I reapplied, I applied to only 3 grad schools, and I got a offer at Stony Brook from my mentor, who's since passed, and he was the guy who really made it public that violence on television can be translated to kids, demonstrated that in research, and then shows like Sesame Street and the Electric Company and all that came out of his research, because we model like the Bobo doll experiments. I don't know if you know about that, but when children witness violence, they will perpetrate it. And back then TV was like a renegade. So him and his group put out that research. And anyway, we ended up researching chronic pain, and that's how I got interested in pain. But he was just a, sort of like a grandfather theorist of psychology. So it was like amazing to learn from him.
What was his name?
Bob Liebert. Yeah, he trained with this guy called Walter Mischel, named Walter Mischel. And Walter Mischel was like the big violence researcher, and Bob was in his lab and kind of carried some of that out.
What was it like to be so close to that kind of experience?
He was a really humble guy. Mentally, that's what I wanted. I wanted pure science. I loved being on the side of proving things. And, I did lab work. I ran a lab. We did experiments. And that's really what the kind of the foundation of psychology was years ago, of proving things and showing associations and cause and effect and things like that. And so he was very entrenched in that, and he taught me that, and that kind of is what really drew me in. There was a lot I didn't know, and I think there's a way of delivering that as a science that's, that just I wasn't aware of at that time.
Well, psychology is this delicate balance of a humanity and science, but you approached it from the beginning with a scientific background.
Yes.
Attitude.
Very much so.
And then so Stony Brook, right? You get your PhD there, right? Where do you go from there? How do you end up this far south? You're from New York.
Everybody asks me that question.
Yeah, everyone's dying to know.
I call it the Austin of Mississippi. That's what I call Hattiesburg. So in my field, you have to complete a residency. So you apply for those all over the country. And I ended up doing my residency in New Orleans at the New Orleans VA. And I specialized in trauma and chronic pain, behavioral medicine background, and loved New Orleans. Spent a year there and really felt, I think like so many people do about New Orleans, it was like my city. You can make it your city. And then I did a fellowship in Baton Rouge at LSU at one of their research facilities that's called Pennington Biomedical Research Center. And they are world renowned for studying behavioral medicine and metabolic syndrome. So basically how weight loss and weight gain happen as a result of behaviors, also as a result of biology. And so they're really at the cutting edge of that. And so I found another mentor there, which was kind of just accidental. I was in New Orleans and I was looking around for training experiences, and I found a guy named Phil Brantley, and he's a godfather of behavioral medicine. I had never heard from him, and he interviewed me and was kind of like, "What's a New Yorker doing in Louisiana?" And I said, well, sir, I just really want to be here and I want to learn from you. And we had a great year together. So I did a residency, a fellowship, and then after that, I was ready to work. And I really planned on working at LSU Health Sciences Center. I had an offer there, but like a good New Yorker, I needed a counter offer. And I ended up being interviewed at Forest General. Funny story there too. The guy who interviewed me grew up in an area not too far from my parents. So that was weird, like on Long Island, years ago. Anyway, so I came to Hattiesburg and they swept me off my feet and they offered me a fantastic position as a director of a pain management program, which I was a unique person. At the time, I was the only fellowship trained person in the state of Mississippi doing health psychology or behavioral medicine, and I think I still am. But it was really novel to me that a small town like Hattiesburg would want a pain psychologist, which is really what I wanted to do. Chronic pain is essentially a public health crisis in the United States, and it has been that way for a number of years. I mean, the impact of chronic pain on the American economy is $565 billion per year. It outpaces cancer and heart disease combined. So real pain. Pain is real. It lives in the brain. By definition, the brain is the seat of everything, physical experience and emotional experience. There is no way to separate the mind from the body. If we cut your body away from your brain, you're dead. And similarly, the experience of pain at the level of the brain, the spinal cord, the neurotransmitters, it will magnify or minimize any psychological issue. So if you take someone with chronic pain and they have depression, they're going to experience their pain at a higher intensity, like an 8 or a 9 or a 10. But if you take somebody with chronic pain who doesn't have depression, they might experience their pain as a 4 or a 5 or a 6. And these things have been repeated in research over and over. And it's because things like depression, anxiety, catastrophizing, weakness and deconditioning, even diet, can radically influence the experience of pain. And pain is defined as a physical and emotional experience of suffering. Suffering is an emotional concept. And for anyone who's ever had pain, the feeling of physical pain is unpleasant, but the emotional cascade that comes with it is the suffering. I can't work. I can't do the things I want to do. I'm gaining weight. I look ridiculous. I'm not the person I used to be. I can't do homework with my kids. I can't run. And these things have an emotional impact on us because they're connected with our sense of identity. So it's kind of radical to think that pain wouldn't affect your mental health. And so the process of pain psychology is really starting to understand that, how pain affects mood, sleep, energy level, motivation, sex drive, interest in hobbies, identity. And because we really can't argue with that, what we start to do is try to find commonalities with people about things that we can work on in spite of the pain, or things that can actually help the pain. So we know, for example, that there are certain techniques that calm the central nervous system that can dull the sense of pain. There are techniques including breathing and meditation, and there are diet changes, there are behavioral changes. We know the weaker that we get, the more pain we experience. In order to do a physical behavior, though, you have to have motivation. That's psychological. You have to have hope. You have to have interest. So everywhere you turn is the mental health aspect in pain. It's dramatically ignored in medicine. Here at the practice, I'm lucky to work with a lot of referring providers that see this connection, that realize that pain medication or surgery may be one piece of the problem or one piece of the person's recovery, but it's not the whole story, that we have to treat the whole person and tailor treatment to them in order to help them recover. And I worked for them for 7 years, and it was great. I worked with surgeons and PM&R docs and worked on the cancer unit and worked with USM. We still have students from USM that we train that are getting their PhDs and are training to do what I do. And, you know, I just had such a great reception from them. I worked in the Pine Grove programs in addictions and with a lot of the well-known people in this area that do addiction work. And when I left, I started this practice. I just kind of went out on my own and wasn't really expecting it to become what it was. I figured, well, everyone was telling me 3 to 6 months, maybe 2 years, and I started in this building in a very small office, and in the first 2 weeks I got 250 phone calls.
Wow.
And we haven't stopped since. We're in our 11th year this year.
How would you describe Southern Behavioral Medicine now?
Now we're a multidisciplinary practice that kind of covers everything from what we call general therapy, depression, anxiety, trauma, panic attacks, all the way through specialized therapy and forensics. So because I deal with chronic pain and help a lot of people with medical problems, we have a rehabilitation component to the practice. We ran a pain rehabilitation program for a while. We suspended it during COVID, where we worked with physical therapy, nutrition, massage to really bring holistic care to people with chronic pain. And I do a lot of forensic work because a lot of people who have had injuries end up being represented, and they need a subject matter expert or a provider expert to give opinions about their case or their care or where their care is going or what their prognosis might be.
Maybe to somebody who wants to get help but doesn't know how to go about it, how would they get involved, and what kind of services do you provide that are different than the norm?
I think we're really unique. We're the only practice that does the scope of things that we do, accepts insurance, and has licensed providers. So I think that really sets us apart. We're different also because of our personalization. We actually try to match people with a therapist that we think they'll be a good fit for. We take into account their insurance. We take into account the therapist's background and the person's presenting problem. And I see that as something that's almost never done anymore. I mean, healthcare has just become so depersonalized. So that's a huge piece of what we do, treating our clients as customers, really listening, screening, being honest, and trying to be as helpful as possible while working within the constraints of their insurance or whatever the case may be. For people who are looking to get connected, I think honing in on what it is that they need or want. Is it an answer to a question? Is it, do I have a diagnosis or not? Do I have ADD? Do I have bipolar? Do I have autism? Or is it more of like an experiential question? Like, how do I deal with this news in my life or this setback in my life? Or how do I deal with this diagnosis? Or people keep breaking up with me. What is the challenge? You know, everywhere I go, there I am. I keep getting the same feedback. I'm starting to wonder, is there something there I can't see? So I think really knowing what it is that you want from a psychologist or from a provider is really important. Or assessment. You know, we do lots of different types of assessment.
Does something have to be catastrophically wrong for someone to seek help?
No, but that is often what brings people in when they feel really unraveled or really distressed or really confused. We try to encourage people to come in even if things are well, because there's always a way to optimize where you're at. But also not to wait, because there's a phenomenon I think that happens when people come in and they're so overwhelmed and they want to be heard, but they also want results really quickly. And if you think about how long it took for you to get unraveled, to expect it to turn around quickly is pretty unreasonable sometimes. So I think that can be frustrating for people. On the other hand, sometimes when people come in and they're really distressed, they're just so happy to be in a place that they're heard. So it kind of depends.
What are some things to look out for to know that you might need to seek help?
One of the things that people have said to me throughout the years when they come for therapy is, I don't feel like myself. That's a really vague statement, but everybody kind of knows what it means. If you don't feel like yourself, if you feel like an imposter, if you feel like you're keeping up a mask, if you just feel numb or strange, or you're not feeling at all, or you're feeling too much, that all of those things are signs that you're out of sync with what we might call your identity. Other things, I mean, there can be really overt signs like crying all the time, not sleeping, low energy, or high energy at times when you wouldn't expect it. Feedback from the world, your job, a partner, friends, that is negative, or people sort of breaking off from you or not inviting you to places, or you not feeling effective in your life. Lots of people come in and they'll say, I don't really know that anything's wrong. I actually have a lot to be thankful for. Everything seems great. I just don't feel like myself. I don't feel like I'm in the right place. I don't feel the way I want to feel. So you can tell there's some sort of space. There's a little bit of difference there. And that's the opportunity for therapy.
How important is it for you to check in with how you're feeling? Because that's something that we're starting to, as a society, accept, right, and it's being normalized, but it's still early days. Like how big of a deal is that?
It's huge. I mean, I think the pandemic has really, as you said, increased awareness. I've never seen such an attention to mental health in the news. The Wall Street Journal, the New York Times, I mean, sports magazines. I was just reading earlier today about the basketball player, I can't remember his name, who just reported suicidal thoughts after he did a big endowment ceremony for his mother. I mean, this idea of us becoming aware, I think the pandemic forced us into isolation, and then all we had to do was look in a mirror at ourselves and also experience the stress of uncertainty and threats to life and health. And, you know, when you think about that from a brain perspective, you get primitive in a way. You know, when you take away all of the stresses, we're only left with primitive needs. You know, who am I? Where am I going? What does this mean? Do I have the means to get there? Sustainability, jobs changed, so much changed. So it's really understandable that the shift to mental health happened. I just think it's amazing and wonderful how welcoming people have been about what mental health, from employers. I was just at a large conference of employers and insurers. Everyone's interested in whole health, looking at the person, you know, understanding people, 4-day work week, you know, letting people express themselves at work, understanding that people bring their circumstances to work, and how does this affect things like productivity and a community and connectedness.
Once you're in therapy, what would you say to a patient when they're maybe scared to do the work? We hear that sentence, that phrase a lot, do the work. What does that mean? What does that entail?
Yes, what is the work? We're naturally afraid of things we don't understand. So if someone is afraid of something that they don't understand, we're automatically in an irrational space because we don't even know what we're afraid of. We're just afraid of the unknown. And a good therapist knows where we're going, understands how you map into that equation. And a good therapist will walk with you through the unknown. But the unknown isn't even really the unknown. The unknown is just something you haven't encountered yet. So in therapy, that's explained. You know, there are therapies, for example, for trauma. In 8 to 16 sessions, we can help people overcome trauma, severe trauma, things that people would think they would never be able to package up and get some distance from. That sounds probably pretty phenomenal when you hear it. But back to the science, there is a large body of research that shows that if you talk to somebody who knows how to talk to you, who understands triggers, who understands symptoms, who understands how the brain works, we can shift our brains. Our brains are malleable, they're plastic. And this is the process of therapy. It's really brain work. It's not just talking. You know, you can get support from family and friends, but do they really understand you? Do they know where you're coming from? Do they even have your best interests at heart? You know, they're not objective. When you come to therapy, you're essentially hiring someone to look out for your best interest and to have their training match your problem.
How does Southern Behavioral Medicine get that done? What type of services that you have in place help people do the work, especially if they're reluctant?
First, I want to acknowledge it is, you know, therapy is an investment, and it can be difficult work, but it's so rewarding along the way. It's the best work you can do. There really is no other work, in my opinion, that is as valuable as this work. So it's so intrinsically rewarding, it sort of becomes exciting along the way because you have peace and relief at the end. One of the things that really sets us apart is our ability to diagnose. If you don't know what you're treating, it's very difficult to deliver an effective treatment. And we see a lot of people who have come in and, for example, they'll say they're diagnosed with bipolar disorder, which is a very discrete disorder that has certain criteria that last a certain period of time, has a genetic component, has certain characteristics. And it can look like some other disorders, but it is its own disorder, and it's its own treatment, even its own medication, things of this nature. So the edge that we offer is that first we diagnose the person properly. We do that through psychological testing, through interviews. We're sort of old-fashioned in that way, I guess. We really talk to people. We don't just have them fill out a couple of screeners. We'll hear patients talking about that. Oh, I spent 5 minutes checking some boxes. I met with someone. They told me I had bipolar disorder. Now I'm on, lithium or Vraylar or whatever. So we're distinct in that way that I guess we're more thoughtful and empirical. There's that science again. And then we talk with people and establish mutually agreed upon goals. So we're not progressing and sort of dragging the person behind us. It's a collaboration. And we encourage people to ask questions. We show them their testing. I can't tell you how many people have told us, I've had testing so many times and no one's ever showed it to me. No one's ever explained it. Nobody even told me what I had. They didn't even know what diagnosis they had, even after years of treatment. So transparency, really rooting our diagnosis in science and the actual symptoms of a diagnosis. And then we have therapists that are well trained. Everyone here has a very good background in mental health. We all have different strengths, and they have a lot of experience in providing treatments that work. I really don't believe in providing supportive therapy or coffee talk. That we're not the clinic for that. People come here to get better. We have a pretty broad array of testing that we offer. We conduct neuropsychological testing for things like medical conditions like TBIs, chronic pain, pre-surgical preparation, but also a lot of different psychological testing, evidence-based psychological testing. We test for ADD with the gold standard ADD test. I think, and then when we use those things in combination, we actually repeat. We test for memory, processing speed, IQ, I mean, so many different things. And then there are screeners for different disorders. And really, if you combine those things together, you can see what something is and what something isn't. And you can plausibly say, it is not this because we don't see these patterns.
So you have the scientific aspect, but you're really mixing that with caring for people. How do you balance those two things? Because I feel like they're not mutually exclusive.
Right. I think in healthcare, sometimes they can seem like they are. When I started the practice, my passion is ordinary people, extraordinary problems. That's what I do. I really think it's important that we acknowledge ourselves as human beings and that all of us have strengths and weaknesses. We acknowledge that in the practice by talking to our patients, listening to our patients, accommodating our patients. We try to get people seen quickly. Our wait list is maybe, 4 weeks, 8 weeks. We've heard of other clinics being 6 months or more. I mean, there's a shortage of healthcare providers right now, as everybody knows. We treat people as we would want to be treated. Everything from the way we talk to them on the phone to when we see them in person. I believe the human ability to change is completely often untapped, and it's our passion to wake that up in people and to give them hope. Lots of people who have come here have said that they've gotten more hope here than they have in other settings or more information. So I think that's really what it's about, is about treating people as individuals and honoring that, not stigmatizing. There's not a single diagnosis that should be a stigma to anyone. Every diagnosis is workable, and probably people would be surprised how common diagnoses are in the general population. So just kind of understanding what we have and treating it with compassion.
So what's the best way for a prospective patient to get in touch with Southern Behavioral Medicine?
We try to make it super easy. People can call or visit the website. I think the important thing is knowing that it's okay to reach out, knowing that you won't be stigmatized, knowing that you will be listened to. And we answer questions over the phone all the time. So the important thing is just having the courage to reach out and give it a chance. I think it's really important not to give up hope. And the best thing that you can do for yourself is to seek help, because we can't solve some problems on our own. That's my best advice to people, to know that some problems are bigger than us and we need help.
Thanks for sitting down with me. This was great.
You're welcome. It's my pleasure.